Welcome to Let's Talk About Cannabis and Healthcare. If you are new to the platform, my name is Drudys Ledbetter. I've been a clinician for over 20 years, and I am your host. These conversations are intended to help clinical providers understand the complexities of bridging cannabis and healthcare in an all-inclusive way. And this merge requires a very interdisciplinary approach. So that means many departments that serve people have to come together and start to understand the pains and the needs of the industry and healthcare so that we can actually bridge this responsibly. So on this session, session 3, the Schedule 3 medical cannabis opportunity, we are talking to Shekia Scott. I'm so excited about building a better integration between medical and adult use cannabis. For those of you who are not very familiar with the industry, our state has a medical program, which is under the Cannabis Control Commission, and it also has an adult use program. And they're governed by different legislative requirements and different guidances. So there is a gap, and there is sometimes friction between the medical treatment centers and the adult use licensees. So we're going to talk about what it's going to take to kind of bridge us together and some of the legislative needs that we're going to need on the back end. So I'm honored tonight, absolutely honored to have Shekia Scott joining the conversation. Shekia Scott is one of the most respected cannabis voices in the state of Massachusetts. Shekia serves as the Senior Cannabis Business Manager for the City of Boston and is a member of the board of the Cannabis Regulators of Color Coalition. She's also the former inaugural director of equity and community outreach for the Massachusetts Cannabis Control Commission. Again, one of the most respected voices in cannabis policy, community engagement, business development, and equitable industry growth. Her work sits at the intersection of government, regulation, business, and community impact, which gives her a unique perspective on where cannabis policy has been and where it may be headed as it becomes more healthcare adjacent. As we start to pay more attention, especially in the era of Schedule 3, there are important questions emerging around patient access, health equity, healthcare integration, public trust, and the role of government in shaping what comes next. Shekia, thank you so much for joining me. Welcome to Let's Talk About Cannabis and Healthcare. How are you?
I'm so great. Thank you for having me, Drew. I'm excited to be here. Let's talk cannabis, because that's all I talk about for the most part.
No, that's so awesome. I wanted to just jump right in and start with your story. So many people know your title. They know your accomplishments, especially having had the state level authority over creating one of the most successful social equity programs in the nation. So kudos to you. But people don't always know your journey. So tell us a little bit about your path into cannabis policy and regulation. What drew you to this work and what keeps you committed to it today?
Yeah, I think it was a lucky synchronicity or a happenstance, and life takes you where you're supposed to be. I started off in healthcare. I was working in healthcare, studying biology, on a path to thinking I was on a path to getting a neuroscience degree. And that's just not the way it was going. I was just very early in my educational career in biology, but was working in healthcare as a senior rep at a health insurance company, doing all types of things. And I got into more so policy and legislation in terms of the climate that we were in socially around the murder of Mike Brown. And from that, one of my close friends and also a major voice in the city of Boston, Shagun Idawu, we were like, we need to do something here. And we ended up from that creating a community group that wrote the policy for Boston's body camera law, which took us 5 years to get enacted through the city council and the mayor at the time, and is still ongoing today. And so from that, there were eyes, and I ended up becoming a director of policy and legislation for a city councilor and a city council president. And then from there, just by happenstance, and that's why I say a lucky synchronicity, a former commissioner at the Cannabis Control Commission in its very, very early stages, Shalene Title, a really, really respected voice in this industry and now in AI, sent her equity ideas and policy to my city councilor's office. And she wanted, she was interested in what city councilors were thinking, et cetera. And as the director of policy and legislation at that time, it landed on my desk to take a look at and see if I had any suggestions. And from there, Shalene and I started engaging, and I was like, oh, I love this. This is the kind of work I should be doing. And I gave her some suggestions. We started talking. And then within 4 months, without a lot of the backstory, I was working at the commission.
Oh, wow. That is so amazing, because I was just talking to you backstage, and I was saying like how much we've heard each other's story fragmented. That was pretty awesome. I didn't realize that's how you guys met each other. I know that we've connected a lot through the work of the Parabola Center for Law and Policy, because this is really like the think tank, the mastermind of all the regulators that are thinking about people over profit. So I thank you for your work in that space as well. That is so amazing. So tell me, everyone, since April, could you not, everyone's talking about Schedule 3. There's been 1,000 webinars from attorneys, 1,000 webinars from legislators. We've been on some webinars, the Drug Policy Alliance. Everyone is trying to clarify the message, the urgency, the fact that we should have just descheduled the plant because nobody should be in jail for cannabis. That's ridiculous. And we just need to free the plant, right? But what are we getting wrong about Schedule 3? And I know that when we've talked in the past, I've shared that I think Schedule 3 is an opportunity in some ways, and that we can't throw the baby out with the bathwater. We have to say, okay, this is where we are. Yep. How do we leverage this for equity? How do we leverage this for community engagement? How do we leverage this for transformation and to protect our people? So some people see that Schedule 3 is going to be very transformational. Some people think it's not going to change much. So from your perspective, what are people overestimating about Schedule 3 and what are they underestimating?
Absolutely. So I think there's two things before we get into what people are overestimating and underestimating. And the thing about Schedule 3 is that it's just incremental justice. And maybe let's not even say justice. It's just incremental progress. And so, yes, we should absolutely be descheduling the plant. And not just because people shouldn't be incarcerated, they shouldn't be criminalized and continue to be criminalized and impacted in the variety of ways that we are, right? Arrest is just the highest level. Well, not even arrest. Incarceration is probably the highest level of disenfranchisement, unless you lose your life as part of the war on drugs, which people have. But there are many, many, many instances of disenfranchisement that fall underneath the severity of incarceration that we need to be thinking about in terms of criminalization of this plan. But I think what people are overestimating about Schedule 3 is just how quickly it could fix the day-to-day realities of patients and just the industry in general. But I also think they're overestimating what Schedule 3 is, just in the core of what is being said about what Schedule 3 is. Cannabis, marijuana, whatever you call it, dank, whatever you call it, has not been rescheduled. That's right. Medical products in specific categories have been rescheduled. So if you're using, selling, buying, whether legally under your state programs or your municipality, anything outside of those two areas specifically of products that have been rescheduled to Schedule 3, you are still buying, selling, consuming, using, taking a product that is Schedule 1. And so it's a very limited scope. And I think people are overestimating, like, because they're just generally saying it's Schedule 3 now, and it's not. And so it's a very, very specific language and very, very specific products, which are medically licensed products under your state's guidance, and FDA approved medical products, which is a very, very, very limited scope. And so I also think that people are overestimating, again, as you said, the quickness in which this is going to alleviate those day-to-day realities and issues that people are having generally, right? It does not automatically mean federal legalization. And I think people kind of overestimate rescheduling as legalization. This does not legalize the plant. The plant is still federally illegal. It just has it has alleviated some of the barriers of Schedule 1. And it doesn't give us any immediate protections for those employees, from your landlords, for your healthcare barriers, for your educational barriers. It doesn't decriminalize the plant at all. And so you're still subject to all of the same realities that you are under it being federally illegal. I think another thing that people are overestimating is that this is going to just open the floodgates for anything to happen. And there are so many things that still cannot happen. And because people are confusing this with legality, they're not thinking about the FDA approval processes that may be a part of this, the DEA processes that are going to step into being a part of this, which we've already seen. We've already seen them create a registry, and how that's already bumping up against state legalized programs in a variety of ways, right? Language is mushy. There's not real guidance. There hasn't been any guidance from the federal government in terms of what this means. Do people have to register? Can they still operate legally under Schedule 3 without registering with the DA? So I think people are just like, they're looking at it and excited for it, but it's an overestimation of what it's actually doing. And I think people are underestimating how much like operational confusion this is causing. Right. In Massachusetts, we have a dual licensure state, and so do a bunch of other jurisdictions. But a dual licensure state means that we have a municipal process that happens in conjunction with our state process. And civics is already a major thing. So we're having 3 layers: federal, state, city, all trying to interact with each other without talking to each other, without coordinating with each other first, and then trying to explain those things from each of those different vantage points and perspectives, and then how they go together. And so that's causing a lot of operational confusion, and not just for the city, the state, and the federal government, but for providers, for patients, for consumers, for operators. Like, how are they supposed to navigate this? Where's the one place where they can get all of this information in one setting? And we're experiencing, again, like I said, those 3 separate layers of different directions, different barrier levels, and different hurdles for people to go through just to get to a registration under Schedule 3, or a license, or a medical establishment.
Yeah.
So
that is so brilliant. I'm sorry. Did you have more? Because you're on one, and my brain is exploding.
No, that's okay. I mean, I think there's a lot there, of course, and I just said a lot, so definitely feel free. I know that the one other thing, again, is that we're going to touch on it, but that divide in medical and adult use when it's the same exact plant. I think people are underestimating the confusion that that's causing, that we're using the same plant for literally the same things. Everybody's medicating if they're using a medicine. But there's two separate processes, even at the federal level, for rescheduling of both of these sides of the coin. So medical and non-medical rescheduling are happening separately. Some medical products have been rescheduled right now to Schedule 3, and we're waiting a federal hearing on June 29th for the broader rescheduling of just cannabis or marijuana as a whole.
Yeah, and the reason, like, I'm glad you went and touched on that, because there's a few things that I think people are getting mistaken when it comes to Schedule 3. And Schedule 3, it's like, I went to Jamaica once, and I'll tell you the story because it's very relatable. And I was driving in Jamaica with a cab driver, and he was going really fast. And I was like, hey, is that the speed limit? And he said, it's just a suggestion, right? Ooh. And the reason he said it was just a suggestion is because if it's not enforced or if it's not mandated, it is just a suggestion.
Yep.
If you don't have speed radars out there, those numbers are just a suggestion. Like, you should probably go this fast, right? But the minute you add a mandate to it, it makes it more than a suggestion. And there's two sides of the coin for healthcare. One, that now we have people walking into healthcare clinics, hospitals, facilities. I experienced this where somebody was a medical patient, brought their card, had their whole little system set up. And we were like, we can't help you. We don't have a policy for that. And in healthcare, everything runs on a policy. Yep. If it's not a policy, if it's not a mandate. And then the other thing is, we can't do med reconciliation for that because our medical products are not part of our formulary, statewide formulary that pharmacies have to use to access to see if there's any med interaction risk, which happened to me. And I had a lot of concerns because I was like, let's say it's not safe enough to disclose. We know that patients are telling us that. The Cannabis and Healthcare Experience survey that's going on right now, the preliminary results have shown us two things. One, 80% of people accessing adult use dispensaries in the state of Massachusetts are doing it for therapeutic reasons. So that means that our adult use dispensaries are a very important point of patient access and should be part of our public health infrastructure. So that was the first thing. The second thing is that we now in healthcare today have patients who are walking through the door with legal Schedule 3 medications. And in healthcare, we don't have the language or the understanding or the data fields or the resources to properly document this medication and follow the existing federal mandates. And in healthcare, you were talking about, I called it the Swiss cheese, when you have federal, state, and city, especially in cannabis, because it narrows your scope of what you can actually do. But in healthcare, we are governed by like 6 or 7 overlapping bodies. Reimbursement is impact, the scope of success for healthcare is so narrow that we don't have room to not be able to see this and not be able to see the risk that it causes in healthcare. We don't have room to not be able to know which patients are consuming so we can start data collection. We just don't have the room. So, but for years, healthcare and cannabis have largely operated parallel in silos rather than together. Even when the Cannabis Control Commission was formed and the medical program was moved from the Department of Public Health over to the Cannabis Control Commission, there was never a bridge or an idea to create a bridge so that these two entities could stay together in some way and data share in a significant way and actually create reports from the data that we're already collecting for the Department of Public Health to be able to really put a picture together for Massachusetts. And for the last 10 years, we have all this data that's not intersecting. And that's how we ended up having that conversation this April when we were saying, what is the role of healthcare in repairing the harm that, the war on drugs cause on health equity? That is because the DPH data and the CCC data is all open data. So if somebody like me, which I did, grabs all the data sets and does an analysis and overlaps the healthcare disparities with the areas of disproportionate impact, to me, it tells a very clear story that the war on drugs had a health equity impact, especially in our state. And for us to have separated those two industries to make them silos was a mistake that we're early enough to correct. So as these industries, right, healthcare,
Mhm.
CCC, they begin intersecting more directly, where do you think healthcare organizations should be paying closer attention, especially from a regulatory point of view? And what kind of conversations should healthcare leaders be having right now that they're not having enough of?
Oh, there's so many, and I don't think that like you said, the onus is just on the healthcare providers, right? It's bridging that gap between all of these regulatory boards, right? We have regulatory boards and people in just strategic positions in cannabis at all of these levels, right? The city should be having those conversations with our healthcare providers in our hospitals, in our clinics. What does that look like? Do we have any guidance on that? Do we have any educational materials? We should be working together, maybe in monthly or quarterly meetings to be on the same page of what's going on with this, because cannabis is healthcare. Medicine is healthcare. And so what is going on in terms of regulatory policy, et cetera, with this plant that intersects and doesn't intersect with healthcare? And how are we working together to generate public awareness, guidance for each other, right? People come to regulators to talk about healthcare things. We can't regulate the hospital, as you stated, right? But we can have those conversations on their behalf. Who are they supposed to talk to? If somebody comes to me and the most I can say is, oh, you should talk to your doctor. And then, like you said, they go talk to their doctor, and the doctor doesn't have any of the tools that should be readily available for them to actually have this conversation with them. So I think that is where we're losing the buck, right? And at the federal level, again, like I said, they push this out with no guidance. But I do think there is some guidance just on on Schedule 3 in itself, because it's already existed in terms of what Schedule 3 allows, and what it doesn't allow in terms of, pharmaceuticals, right? And that's also something people are underestimating in terms of federal regulation. We're moving in the way of big pharma when we get into the scheduling of cannabis, which is not like the freedom that alcohol and tobacco has, which are not scheduled substances at all, even though they have been proven and scientifically studied to be proven to be more dangerous. But we need to work both from the bottom and the top to meet in the middle of an aligned strategy of what this looks like. And like you said, not just policies, because policies look great on paper and they don't always translate to practice. And we've seen that time and time and time and time and time and time and time again. Yes, it's great. I feel like policy is the ideal. You write down your ideal, you try it, and then you see what's realistic. And I think that we've been trying to regulate and policy our way out of medicine and healthcare, and understanding that these two things are related. But we've also been trying to regulate and policy ourselves out of bridging that gap, because we've already made that distinct separation that these two things are different. And realistically, what we're trying to decipher is just how you're taking this medication and how you're accessing it are two different things. Some people, while they may not consciously understand that, hey, I'm using this for medicine, I'm using it recreationally, that's kind of the separation that we're making. But we've made two separate industries, while we're trying to make that separation of like, hey, I actually have an ailment, maybe physical, maybe mental, maybe chronic, maybe not chronic, but that I know was diagnosed by my doctor that cannabis helps, and then someone who's like, I just want to chill out sometimes, and maybe they don't understand it's because their mind is racing, etc., and they haven't been diagnosed with anxiety or whatever it may be. Or sometimes they're just like, this just makes me feel good and I want to smoke, or I want to take an edible, I want to take a tincture or put a balm on. So I think that's where we're really losing out. Um, Partnership between healthcare and in just our cannabis regulatory boards. But also we're losing out in other areas. That entire framework should be developed for housing and education and other areas that the war on drugs touches, because people are not only disenfranchised medically, but all of these things fall under medical and health, because when I'm disenfranchised and I can't access education, I can't access housing, and I can't access employment, my health decreases. And so all of these things point back to healthcare, and making us more healthy and alive. And it just depends on, what who we're putting in these positions and how they're envisioning what their work is, and not just stopping the buck at regulating the business aspect of the plan.
No, and I am so with you. Like, you are blowing my mind today because you make me think of all these other things that I haven't considered quite yet in terms of like the interdisciplinary approach. And like when you were talking, I was thinking this FDA box that they're trying to fit cannabis in, we're not going to fit. Like, there's no way without dismantling the entire industry that we will ever fit into an FDA pathway. But there is a way with the data that we have and access to the metric databases for our medical products to actually build a similar model that gives you the same outputs as the FDA pathway so that clinicians can make the proper decisions at the point of care. And I'll give you an example. The things that you get out of the FDA pathway, especially for pharma, you get indication of use, right? Because they've tested it against research and they're getting indication of use. We have tons of apps, Tetagram app, like that kind of app that where people have been disclosing their indication for use. We need to aggregate that data and
Yep.
look at it and say, what have people said is their indication for use? What does our medical metrics, seed to sale tracking say that people are using? And start really building a medical formulary, whether it's at the state level or the federal level or national formulary, where the clinician can just access the same information and can then document it in the medical record. Because when you're documenting a Schedule III medication or when you're ordering one, you need to write the indication for use. Because if you don't have these nuggets, that order is not a medical order. You need to know why, who, how, the dose.
Yep.
We don't have dosing guidance either. We have all this data that we're collecting, and we're not aggregating it in a way or asking people about their dosing. Like, that's an easy cannabis intake questionnaire right there. Ask them if they consume. What is the indication of use? What is their dosing? That is an easy way to get a baseline of what's happening in your own facility, in your own state, even if you wanted to pilot this, just so that you can see it. Because the truth of the matter is, as you mentioned, social determinants of health, poverty, housing, transportation, food, employment, all the things that were harm done, that compounds with human experience and behavioral determinants of health. And I call behavioral determinants of health cannabis consumption, alcohol consumption, supplement use. People don't talk about that enough. Everybody's on ashwagandha, and people don't realize that interacts with some medications too. So like, you should look it up. Or alternative therapies, people who do fasting and to take other medications that are not necessarily approved or smiled on here in the United States. Sleep, exercise, the traditional behavioral determinants of health. All of those impact clinical outcomes. And those clinical outcomes are all tied to financial outcomes. And I think the more we ignore it, not only are we going to widen the equity gap in health equity, but we're also going to start to see the cost of healthcare increase. And we're not going to have visibility to what's happening in terms of readmissions, ER utilization, medication interactions, especially medication interactions, or disease progression. Why are people getting off meds? I've had numerous friends that came off seizure medications because of cannabis, and their doctor just doesn't know, and they're just like, oh, you don't take it anymore, okay, and they just delete it, and there's not a real conversation, so there's no actual proof of the benefits and the medical benefits and the impact cannabis has already had in healthcare. And like that whole social determinants plus the behavioral determinants, that visibility model, we don't have a full picture because we're not talking about cannabis. We're not talking about how grief, how trauma, how poverty and isolation and stigma impacts health outcomes. Because like you said, you think you're just doing it to feel good, and you really have anxiety, you really have stress. Let me bring it back in, because
Okay.
one of the themes that we talk about often is that patients don't experience healthcare, housing, employment, public policy, and cannabis separately. All of this is happening as a whole experience. It's a human experience. So again, social determinants of health, behaviors, alternative therapies, all the things that people are doing, they're experiencing that as a whole. So if I bring it back to the visibility model, and this is again something that this work has brought me to. The social determinants of health is what we can see in healthcare. We can kind of see the human experience, and I think as a nurse, I'm a little biased because nurses are closest to the human experience in healthcare. We're the ones right at the bedside. Our nurses and our CNAs, shout out to our CNAs. But we don't have a way to document that or track that or see that in the way that is measurable. So like if somebody just lost their mom and all of a sudden they're in the ER for like headaches, and you don't know that, like we don't have a way or some data map that tells us, hey, this person may be experiencing grief, can you also assess for or refer to, then we don't really, like we don't have visibility if we cannot actionalize it. And then you have behavioral determinants of health, and the only thing we really have visibility to and is exercise and sleep, and we do it in like ranges, and these ranges haven't been, pressure tested since 1972. So like what you think is healthy in terms of ranges, in terms of data capture, not what you're supposed to be doing, because research is up to date on what you should be doing in terms of exercise, sleep, and diet. But in terms of the way we capture that information in the medical record, we're not even doing that in healthcare. We're not saying research has updated. We update the recommendation, but we don't then reassess, hey, now that there's this new recommendation, what else should we be measuring and trying to see, because it could impact clinical outcomes.
Right.
So cannabis kicked the door wide open. It absolutely kicks the door wide open, because it's now saying, hey, human experience, you may want to capture that. That'd be nice. That's a nice to have. But now medical cannabis is a must have. So how do you handle medical cannabis? And if we're only seeing the social determinants of health and like a little fraction of behavioral determinants of health, we're not seeing the whole patient, because the whole patient is experiencing healthcare, housing, policy, and cannabis all at the same time. So when you think about the patients in the communities, you touched a little bit on housing.
Mm-hmm.
Where do you still see the biggest gaps between what the the system intends to do and what people actually experience? Like I think that's the health equity gap. Where do you
Mm-hmm.
see that from your perspective and your lens?
I think the biggest gap, again, like we talked about, is that first creation of the separation of the plant from medicinal and recreational. That creates a real wide gap, because a lot of our early, especially in Massachusetts, a lot of our early focus was on medical treatment centers, and then largely shift to recreational dispensaries. And that left a gap in access. We're also seeing the decline in medical treatment centers being able to open because they have, and like you said, because they're regulated separately, they have two different sets of regulations and requirements. They have larger areas of barrier to get a medical treatment center going. And so patients then have to go to rec shops that may not have the requirement or standard of having a requirement to provide all of the medical background that a medical treatment center can provide in terms of what you're using, what dose is it the best thing for your actual ailment or what you think you're experiencing medically. And so I think just access in general is one of the biggest divides. And then pricing. Right, geography, stigma, as we talked about, registration ties into pricing, but pricing around there's two layers of pricing around the products for the consumer and pricing around entering the business to provide the products to the consumer. Massachusetts alleviated our registration barriers because we had prices connected to that. And so I think there's just access and education, like you said, those are the main gaps. Protections, right? There's still no lay of the land, just overall policy of how you're protected if you use this. And then, like you said, housing. If you live in federal housing, but you are a medical patient, right now in the state of Massachusetts, you legally, unless you like go to a friend's house or, somewhere where you legally though, in terms of like a safe consumption site or any consumption site, don't have anywhere to go. And you risk losing your housing to medicate yourself in your own home if you live in a federally stabilized home or housing. And so that is a big gap. Massachusetts is looking to close it by regulating social consumption, but it's still a business model. You still have to buy rather than you have to buy on site to then consume on site. And so if you just have your medicine with you already, you can't just bring it somewhere and consume it safely. And so that's going to be a huge divide. And then just like we talked about earlier, the fragmented rules, the layers of civics, city, state, federal, those all create so many different gaps. What do I need? Does even questions of like, well, does my medical card work everywhere in the state? Like some people don't understand that. It's like, okay, well, I got my medical card from the state. Can I use it in every place in the state? Can I go somewhere else and get medicine? And so, there's just so many,
Yeah,
many.
yeah. And as you're talking, I'm like docking opportunities for public education campaigns that Project Destigmatize Healthcare can take on as a nonprofit, focused specifically on repairing the harm that health equity caused. That the war on drug caused on health equity. Honestly, through the lens of access, education, and data collection. So a research-based nonprofit out of here in Boston, Nurse Led, I'll plug it. I'm the nurse. But like even that first survey where we're trying to just understand the cannabis and healthcare experience of the patient, is really focused on hearing their voice on what they need. But the other piece of it is truly based on the policy and legislation side of things. And as you were speaking, last week, Mac Vernet Consulting, which is also my company, we put forth a policy proposal to the state to bridge some of these gaps by a type of like, hey, Massachusetts, acknowledge that our medical cannabis program is now protected, so that people have that, and acknowledge that patients have the rights that are afforded to Schedule 3 medication and patients, and kind of do like a handshake, like, yeah, we heard you, federal government,
Yep.
and then really put together a work group of
Yep.
pharmacists, physicians,
Yes.
clinicians, researchers, legislators, public health officials to really start to talk about that workflow, build the workflow from the patient experience perspective, because healthcare is patient experience led. We have surveys that are tied to reimbursement because patient experience matters. We know that the patient experience is high, the outcomes are better. So like all of this is really tied together, and it behooves us in Massachusetts to take a stand and be first at creating a model that the rest of the nation can then follow. So I'm going to offer to just send you that policy proposals to see if there's
Please.
anything else from your perspective. I don't know why I didn't even think of this, but I think your brilliance is throwing me off today, because I've known your beauty as a human. I just we've never connected this deep, like academically, and you are like just blowing my mind. You're so freaking smart. So now let's talk about the medical and adult use systems, right? Because you just said they were never really designed to work together.
Right.
So we have patients navigating both systems.
Yep.
Some let their registration card expire, but then like they try to navigate both. I've had people say, once a medical dispensary near me closed, I just went to rec because I'm not driving all the way to Brookline. So like, and that is in Boston in particular, which I'd love to take. And if you want to add on that, and the fact, I'll give you guys some data and some background. When adult use expanded, what happened in Massachusetts is that the medical program registration and providership declined. And we did a data study in partnership with the Parabola Center, and put out a paper showing like the fact that we lost 40% of our original crew. And the question really was, where did they go? They went into rec. And in Massachusetts, our adult use market is under attack right now with a potential ballot question, cleverly named, let's responsible marijuana initiative, whatever it's named, right? You're not restoring responsible marijuana by eliminating a patient access point, especially when we know, and like I said, the Project Destigmatize Cannabis and Healthcare Experience Survey early results have shown that 79% of adult use consumers in the state of Massachusetts are using adult use dispensaries to access their therapeutic use medicine. They are using it for therapeutic reasons, and this is self-reported. So we need to listen to the voice of the patients. And a lot of the challenge is that these two systems kind of have beef. I don't know how else to say it. Like I go to like, you go to like NECAN and like you see the medical crew and then you see the adult use crew and they don't talk to each other. They don't even go to each other's panels. It's like this little friction between the medical use and adult use systems. Because in some ways, the medical program, and I mean, the data shows it, we became like the forgotten child because the golden child came in and started doing flips and bringing billions of tax dollars into the state. So like, who cares about the patients? And they felt that, and they've been talking about that. So where do you see, like, considering that patients need the resources and they need access, where do you see the biggest challenges that were created by that disconnect, by making these systems so separate that they got beef?
Yeah, I think the biggest disconnect is that we've entirely disconnected from what the plant is, and that it is just one plant. And so we've created these two ideas that one thing is one thing and one thing is another when they're literally the same exact thing, which is the plant. It's just one plant. We're not using two different plants for medicine or medicinal cannabis than we're using for recreational. It's one whole entire plant that's being used in both of these. So we're creating just an educational divide and understanding of what cannabis is generally. And then I think that funnels down into everything else. And like I named, we're also pushing medicinal patients out to rec, which may not have or required or are required to have the medical background to basically dose or suggest products based on what a medical patient needs. But I do want to offer some non-divides that Massachusetts is trying to fill right now. And not that they understand that they've created this divide, but I think federal rescheduling has added some alleviation to this divide for Massachusetts, because Massachusetts, under a new state law passed earlier this year, set an exclusivity time frame on medicinal licenses for equity business owners, and so or interested applicants. And so more people, alleviating some of those barriers into that in industry, or that side of the industry. It's not a separate industry. And so more people will now be able to have access to opening medical treatment centers, because the barriers were so high to even interact in that space. And we're not the only jurisdiction that has that. We also grandfathered in our medicinal dispensaries so that the industry could get a kickstart, which was the biggest mistake that we made. We should have not done that. It makes sense in policy, but not in practice, because it created this divide. But there is some relief, and we're even seeing at the municipal level, people are now engaging more with wanting to open medical treatment centers because it's accessible to them. Even just opening the businesses and being able to provide through that avenue was a barrier. And so I think while it's great, we still are going to have to see in the coming years the impact that that actually has, and does it increase more medical access, and does it actually increase more medical treatment centers opening up and operating and being successful. But federal rescheduling also reinvigorated the interest in medical, because they limited it to medical licensed facilities. And so people are like, okay, well, now how do I get a medical license? Because they're trying to reap the benefits of medical federally rescheduling. So I think that's an overestimation of what federal rescheduling can do, because now people are going to jump into a whole sector of the industry that they don't know yet, kind of like they were doing with rec. But it's going to give a boost to medical and the conversation around patients and consumers. And we have to just keep pushing for the conversation to focus not just on the businesses, but on the actual patients. What changed for them? What increase, what decrease? Like you said, that study. I want to touch on something about that too, the data that you're referring to. As a municipality, we do and we don't have it, because where does it live, right? The state's data will need to be extrapolated for each municipality. And so even then, if I go to the state's data and I'm like, well, I live in Boston, this says statewide, how do I know what's impacting me or where my access points are specifically in Boston? If I come to Boston, I don't know that. I just know generally what our public health commission studies say, but not the interaction with cannabis. And so what I'm trying to do to alleviate that is do these types of conversations, partner with you and your organizations, and as well as the Parabola Center, to produce citywide specific data points and reports. And created a hub, just a central place to go to for all things cannabis, not just licensing, not just equity businesses, because that's what we're seeing. And we're seeing that disjointment everywhere. We go to the states page, it's broadly about licensing. And yes, they do have a great open data platform. We're one of the first states to have one. I mean, we were the first East Coast state to legalize adult use anyway. So we've had a lot of firsts. But there is data there. There are reports. There are a lot of, things to engage with. But there are a lot of things missing. Like if I'm just a patient, if I'm just a consumer, if I'm just a researcher, we all need to be able to go to one place and see all of the same overlapping information. And right now it's too disjointed. And so I think that's one of the biggest disconnects that remains, and that we need to close the gap on.
No, and I think as a clinician, I always think like the patients bear the cost when these systems fail to align. They're the ones that are accessing their medicine without proper guidance.
Yeah,
They're the ones that are not realizing that their medications and their cannabis interact, their Western meds and cannabis interact in a negative way, and they're having adverse drug reactions that they don't really know what to attribute it to.
exactly.
And they're the ones that really lose out. So I'm just going to put it out there because I like to put things out in the universe. But as we are running the National Cannabis and Healthcare Experience Survey, we'd love to just kind of pull reports together for the city of Boston because we're doing our data collection by zip code, so we can isolate the city of Boston. We're spending a lot of our data collection time in recreational dispensaries in Boston this summer in partnership with Harvard School of Public Health, the TH Chan, which cracks me up because I call them my Harvard THCs. That's the initials of their school, the School of Public Health, right in the Longwood medical area. I have 3 amazing research students this summer. We're going to be at Flower Expo next week, collecting data. We'd love to just pull that data together for Boston so we can have our own data set. I'm a Mattapan girl. I'm Boston at heart. I'd love to make sure that would be an honor to like really partner in that way and have the students and these researchers that are getting their doctorate in public health really produce reports that Boston can own. I think that's important for our city because the health equity disparities and even the longevity disparities for people that live in, 2 miles north of one another. We have too many reports that show the disadvantage of being from a traditionally a majority Black neighborhood, or even the areas of disproportionate impact. That map came from data. Yep. So I think this is an opportunity to really produce that data set and produce reports that the city owns and the city can look at to make their policy decisions. Because I think the other piece and the biggest challenge we'll continue to have is that the cannabis industry has been so sensationalized that we are not making decisions with data. So every policy decision, every legislation or bill that's gone up is all like marketing. And if you have more money to do your marketing, you are going to get people to believe your marketing. Just like, again, this silly ballot question, just vote no in November because they're going to do marketing. They're going to tell you if you smoke a vape, you're going to die. They told us in the state's house, under oath in a testimony that somebody's psychosis increased by 355%. That doesn't even sound right. So like they're going to lie if they have the marketing dollars. So we are going to need to not only begin to legislate from data, we are going to need to like capture the data and analyze the data so that we're making decisions for our jurisdiction. And when you're like you are our Boston czar, our cannabis czar. So like for you to have that level of visibility to how cannabis is impacting all these different ecosystems in the city of Boston, I think that is going to amplify your work and what you can do in our community for us, because we totally appreciate you. One of the other things I wanted to kind of lean in on is Cannabis Empowerment Week, because how could we air this episode the week before Cannabis Empowerment Week without talking about Cannabis Empowerment Week? and really sharing that with our clinician audience and
Yes.
letting them know that Cannabis Empowerment Week is not just for the industry, it's not just for the business owners,
Yep.
it is not just for people that like cannabis. This is your opportunity to show up to events and learn what is happening around you and start to think about what it means for your healthcare environment. What
Yes.
does it mean to have a safe consumption site? If you are a long term care center and we have mandates to provide safe smoking of cigarettes, I bet you DPH is going to come down the pike and say people who consume medical cannabis need to have, a safe consumption space. What does that mean? What policies do you need to have in place? What
Hmm.
happens if your Medicare patient shows up tomorrow and has medical cannabis and then you can, start to get reimbursement for that? How do you capture that revenue if you don't build the infrastructure or the data to put you in a position to ask for that reimbursement, to ask for that money because you've done your due diligence and you've done your education, you've created the safe spaces for your patient. And like if you can't see it, you can't manage it. So I'm always challenging people to manage. You have to see it. So tell us what they're going to see at
Yep.
Cannabis Empowerment Week Boston next week.
Absolutely. So, and I think it's super important because it's going to bridge some of these gaps that we talked about, not just Cannabis Empowerment Week, but in this industry, we have to use our imaginations because we're making this up as we go. And what we're making up will stick. And so you have to just be a more visionary in terms of what is possible. But Cannabis Empowerment Week is next week from June 15th to June 21st. We do this every year during the week of Juneteenth. It is an annual initiative. This is our fourth annual. But this year we are focusing on social consumption. So it's the theme of the week is social in the city. And the first day, June 15th, from 6 to 8 at 26 Court Street downtown, we are doing our kickoff event, which will be an insight into what social consumption is, what it means for the city itself, what the city's internal process looked like up until this point, and how we've been planning internally to ready ourselves for social consumption. And then we will be having the first public appearance from the newly appointed commissioner at the CCC, Ziomara De Lobato, who sits in the social justice seat. And so she will be speaking to us, giving us a good introduction to herself, but also talking about the state's regulations in terms of social consumption and kind of like a high level overview of where the state is in their process. As we know, they just got new commissioners not even a month ago, almost a month ago today, but not yet. And so we will be giving that deeper insight. And then through the week, we'll be taking you through walkthroughs of what this looks like. And why I said this can close some of those gaps that you just, and some of the things you just touched on, Drew, is because there's 3 different license types that have come out of the state's regulation of social consumption. Supplemental on-site, which is for businesses that already have a cannabis space, a dispensary, and they want to add on a space inside or in addition to their operating dispensary. And then hospitality on-site consumption. And these are non-cannabis businesses, which could be hospitals, which could be clinics, which could be any other type of business. It could also be just like your bowling alley, your movie theater, etc. But as we're talking about health, a hospital can decide to get a hospitality on-site consumption license and operate in a space where people directly from or patients directly showing up to the hospital could consume in the hospital
Oh
or
my gosh, that'd be
in
magic.
an area of the clinic. And so that's why I said just envisioning what some possibilities of this could be. And so on day 2 and day 3 and day 4 of Cannabis Empowerment Week, we'll be doing visual walkthroughs of the supplemental on-site, the hospitality on-site consumption license types in actual dispensaries or hospitality businesses to say, this is what it could look like if you add social consumption to your
Oh,
business.
nice.
And then the fourth day would also include the marijuana event organizer license type, which is temporary events. And then that weekend, we're going to be out in the community getting social. So we'll be at Bentopia on Friday, tabling, answering any questions just about cannabis in general, the city of Boston's cannabis teams, including licensing. And then on Saturday, we'll be at the Juneteenth annual celebration in Franklin Park. Also tabling and having a little picnic area for people to come talk to us and understand what's going on, ask any questions that they may have about social consumption. And then Sunday, we'll just be observing and paying tribute to all the fathers and father figures in cannabis and their contributions to the industry.
Oh my gosh, what a beautiful way to end the week.
Yeah.
I'm going to offer you some printed materials from the Project Destigmatize Healthcare team.
Absolutely.
We have a brochure that says how to talk to your doctors about your cannabis consumption and why. It's just some patient-forward education. I'll send you the PDFs because we're still self-funded right now, so we don't need your print support.
We'll print them.
Thank you. But we'd love to get some of that education out there. I will be there with my family, as I always am, and I will be crashing at the Walker table. So, because they make some good food. And Shekia, this, oh my gosh, I can't believe the time has flown for us.
Oh my goodness.
This was so good. We must do this again.
Yes.
We must do this more often. Like, this was such a mastermind. I loved it. Thank you so much for sharing your time, your expertise, your experience, your perspective with us tonight. Conversations like this remind me that, healthcare, policy, community, we're all connected, right? The future of cannabis is not just products or markets or legislation. It's really about the people. It's about people having access. It's about safety and truly treating this like the medicine that it is, and making sure that people have the systems that are designated to keep them safe, actually keep them safe. And that's really the important conversation. So thank you to everyone who took time to watch this session of Let's Talk About Cannabis and Healthcare with our Boston Cannabis czar, Shekia Scott. Thank you so much.
Thank you.
We'll see you next time on Let's Talk Cannabis and Healthcare. Our next session is actually our first live session, so I invite you as well. We've partnered with the National Association of Black Mental Health Counselors, I believe. I think I got that all wrong, but it's the National Association of Black Mental Health Counselors. And we're going to have a conversation about harm reduction and what it means, the history of the language, because one of the only diagnosis codes that we have, ICD codes, to actually document cannabis consumption in healthcare is cannabis use disorder or cannabis hyperemesis syndrome. We only have negative connotated or negative experience coding. So the infrastructure is biased all in itself. We can't even document therapeutic positive use with an ICD code for reimbursement because they don't exist. So we even have to go as far back as that in terms of building the language so that they can speak to each other. But that conversation taught me that use disorder is just like this bucket of things and criteria, and the substance is just what they put in front of it. So the reason you end up going down the same path as substance use disorder is because you are on that path clinically in terms of care pathways. Yeah. So we're going to kind of dig into that conversation and talk a little bit about the history behind that and what equity would mean in that space. We're really just educating also mental health workers, because there's a lot of people in that space that use and consume and take cannabis as their medicine. And some of them need to also take their SSRIs, and that is a very high medication co-exposure overlap. And that's when a team and a care decision needs to be made together. So we're going to talk about what that looks like and how we can start to think and get creative about building. I'm going to be daydreaming about Cannabis Empowerment Week all weekend. So, and I'm looking forward to that conversation live next week.
And Drew, I just want to add two quick things.
Absolutely.
During Cannabis Empowerment Week, the ballot campaign committee will also be joining us with education on the ballot coming up in November and what it means and what's happening. So there will be information about that there too. And you can register for each days of all, you can register for all the days or any days that you're available to come at boston.gov/CEW. C as in cannabis, E as empowerment, W as week.
All right, boston.gov/CEW.
CEW, yep. And this is a whole page just about what Cannabis Empowerment Week is, what's coming up for this year, but you could also see everything that we've done for Cannabis Empowerment Week in the other years as well.
Got it. All right, so y'all see the website is ticking at the bottom there for you guys.
Hey.
Make sure you're clicking, you're registering. I am excited to be there on day one. I'll be joining, of course, the Juneteenth celebration.
Yes.
And I'm going to pop in as much as I can because I didn't realize the visual walkthroughs. We were like, you can actually walk through. That is such a creative way to do it.
Yeah.
I love that. Very interactive. So people can really start to imagine themselves in an environment that serves both type of patients, but doesn't look traditionally so different from the environment they're used to. So that's brilliant.
Yeah.
That is such an immersive experience. You guys are so great. Shout out to the team. Shout out to your team.
Thank you.
Like Cannabis Empowerment Week always blows my mind because you seem to activate the right part of what's needed to really see what's next for people. And even just that, for people to start to envision themselves in these spaces so that we stop thinking of cannabis as separate from and more together with. That is like a brilliant way to have people connect with that messaging. So shout out to your team. That's pretty dope.
Thank you so much. We can't wait. We're super excited for it to happen. And we're super excited to see everyone there. And we're just happy to celebrate Cannabis Empowerment Week and uplift this industry as a whole all the time.
Absolutely. And how can people reach you, get in touch with you, follow your work?
You can definitely reach me by email, Shekia.Scott@boston.gov. I think that's the best way. I'm like social media. I do post stuff, but I'm more like hands off in terms of work. We do have a Boston OEOI Instagram page. That is the Instagram page. OEOI, it stands for the Office of Economic Opportunity and Inclusion, in which I work. And so our Boston OEOI Instagram page, I believe that's our name on all social platforms. But our Instagram holds all of that stuff. You can definitely reach me directly there. But yeah, if you shoot me an email, my number will be attached. I'm free to hand out my number, just not online.
Not online, sister, not online.
Right. Like I'm very accessible. I am the people. I am of the people. I'm not a suit. And so it's definitely easy to connect with me once we're connected.
Absolutely. I love that. Thank you again, Shekia. This has been wonderful.
Thank you, Drew.